Hello everyone. Today I am going to start about health policy in India, and I am going to review certain health aspects and what were the health significant contributions in the area of health and how the policies were being made in health area. Health, which has been defined in 1948 by WHO, health is a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. However, in 1986, WHO proposed another definition, and it revisited and expanded on this definition, and which is like health promotion is the process of enabling people to increase control over and to improve their health to reach a state of complete physical, mental and social well-being. An individual or group must be able to identify and to realize aspirations, to satisfy needs and to change or cope with the environment. Health is therefore seen as a resource for everyday life, not the objective of living. Health is a positive concept emphasizing social and personal resources as well as physical capacities. Therefore, health promotion is just not the responsibility of the health sector, but it goes beyond and healthy lifestyles to well-being. The enjoyment of the highest attainable standard of health is one of the most fundamental rights of every citizen, every human being, without distinction of race, religion, political belief, economic or social conditions. In fact, health has become a support resource to support an individual's functions in wider society rather than an end in itself. A healthful lifestyle provides a means to lead a fulfilling life with meaning and purpose. The enjoyment of this highest attainable standard of health is one of the fundamental rights of every individual without the distinction of any socio-economic conditions or religion or race or caste. The health of people is also fundamental to the attainment of peace and a balanced lifestyle is secure and independent attainment of peace and security, and is dependent on the fullest cooperation of the individuals as well as the states. The achievement of any state lies in the promotion and protection of the health, which is of value to all and which has an obligation to look after the well-being of the people. There is unequal development in different countries in terms of or in matters or in promotion of health and control of diseases, especially communicable diseases, which is a common danger, and every state and every government needs to take preventive and curative measures in order to tackle these communicable or non-communicable diseases. There has to be healthy development of children, which is of basic importance, looking into the immunization so that they should live in harmony in this changing total environment, which is essential for for growth and development, and the extension of the extension to all people of to have accessibility to the medical, psychological and related knowledge which would be acquired by individual to the fullest attainment of health. And there also is about informed opinion and active cooperation on the part of the public, on the part of the public are of the utmost importance in the improvement of the health sectors and health of the people. And the government, they have a certain responsibility for the health of the people, which can be fulfilled only by the provision of adequate health care and social measures. When we talk about health policies in India, when India achieved independence in 1947, it was left on a tightrope that could swindle any time, economically as well as socially and as well as politically. It was drained, it was completely drained out. All the wealth of India was being taken by the Britishers for 2 centuries, and which had forced the trade for the riches for illiteracy, poverty as well as hunger and malnutrition. Then according to the 1951 census, in India's population was around 36.1 crore, and only 18.33% of the people were literate, and overall life expectancy expectancy was 32 years. The infant mortality rate was 145.6 per thousand live births, while maternal mortality rate MMR in the 1940s were 2000 per 100,000 live births. There were only 50,000 doctors across the country and only 75 primary healthcare centers covered an area of around 3,287,263 square kilometers. So if you look into during the independence, the conditions of health sector was extremely low, and it was not even a standard way of providing, there weren't any standard procedures, standard mechanisms to provide healthcare services. And you could see the life expectancy ratio, and it could see the maternal, it was and infant mortality and maternal mortality rate was equally very high. So this had led to the planners for bringing about making certain plans and certain progress in healthcare system. So bringing the people of an utmost inhuman living conditions was an immediate but mammoth task that first set the governors at hand. The governors, the planners, the leaders of the independent India were concerned that there has to be a progressive healthcare system. Along with an impoverished population, they had to counter the colonial legacy of the deeply contested value of public health, which was further jeopardized due to the massive influx of people caused by partition. However, there is no denying, due to the fact that as the country started to pick the shards, public health never received its due attention. It is no coincidence that until a few years ago, India invested only 1.6% of its gross domestic product for health related initiatives. Consequently, after 72 years of independence, India is a global disease burden leader. The share of non-communicable diseases had almost doubled in the 1990s and is a major reason of worry. Undoubtedly, the country did made a good progress in healthcare facilities post independence, with a significant improvement in various health indicators over the years, such as the life expectancy at birth, child and maternal mortality rate, creating a large pool of medical and paramedical personnel among other benefits. However, despite these measures and improvements, health still remained a low priority, with public health spending at about 1% of GDP, much lower than many of its peers with similar tax GDP ratios. Consequently, the out of pocket expenditures in India were among the highest in the world, pushing about 55 million people into poverty every year due to catastrophic health spending. The rural-urban divide in healthcare services remains wide, and with the relative negligence of primary health centers, even the goal of universal health care has eluded so far, which had brought about certain constraint primarily by inadequate public health spending. So a lot has to be done. Then a universal health coverage require public health spending to be more, it requires 5% of GDP. Therefore, both the central as well as the state government need to commit to raising the health concerns and health spending of in a time bound manner. India presently is the second largest populated nation, comprising of 18% of the world's population. However, the large number resource base comes many inherent challenges. India is bearing the double burden of diseases, where on the lower end, malnutrition, hygiene, immunization, sanitation, infectious diseases are major concern, and on the higher end, environmental health and lifestyle diseases and other communicable diseases have raised alarm. Cardiovascular diseases, tuberculosis, cancer, diabetics, malaria, dengue, fever, chikungunya, respiratory infections, vector and waterborne diseases continue to be the major challenges among the latter group that has been provided by the Central Bureau of Health Intelligence 2016. And added to this is the threat of emerging infectious diseases like Ebola, SARS and H1N1 influenza virus related diseases. As per the Central Bureau of Health Intelligence, India is facing the triple burden of diseases, that is unfinished agenda of communicable diseases, non-communicable diseases and emerging infectious diseases. Among the communicable diseases in 2015, morbidity reported from acute respiratory infections was the highest, that is 67%, followed by acute diarrheal diseases, that was 23%, whereas mortality reported was highest from influenza A H1N1 23%, acute respiratory infections 20% and pneumonia 18%. This was being provided by the Central Bureau of Health Intelligence. Hence, the concern of the future decade is not only population increase and composition, but also the quality of human resource. India, as we know, that it is growing rapidly and it is already the fourth largest economy in the world. So, with achievement in economic sectors, India achieved many strides in other sectors too, like life expectancy increased to 65 years and infant mortality and maternal mortality and death rate have been reduced significantly. However, diseases like polio, smallpox, guinea worm and leprosy have been completely eliminated, nearly eliminated. Even the birth rate too is showing a declining trend. The number of doctors, health clinics, primary health centers, nursing centers, better healthcare facilities, accessibility to healthcare facilities have increased to provide healthcare services to many of the remote parts of the country. The success of these is attributed to increased penetration of healthcare services, improved immunization, growing literacy and innumerable initiatives which has been taken by the government and private sectors. However, and even the insurance sector had played a significant role in contributing for the betterment of health. However, the health sectors, if you look into the health sectors in India, the health sector in India is private, is public, government, private or individual owned. And if we talk about the private sectors, healthcare providers registered under the Clinical Establishment Act are owned and run by the individuals or group of individuals, and these consist of dispensaries, clinics, nursing homes and hospitals that may practice allopathic, Ayurvedic, homeopathic or Unani system of medicines. Then public sector on the other hand comes under the Ministry of Health and Family Welfare, Government of India. They too consists of dispensaries, clinics, nursing homes and hospitals that follow various kinds of medicine system. Additionally, it includes all India networks of government health facilities in the form of sub-centers, primary health centers, community health centers and rural hospitalizing, urban health centers, municipal and other government hospital, charitable institutions, religious organizations like churches and NGOs, and public sector bodies like atomic energy, railway, port trust, reserve bank and armed forces also own many of these. So, additionally, pharmaceutical companies, chemist shops, research organizations, medical colleges and other health related training and research institutes may be public or privately owned as a part of the health sector. The central government provides a broader framework and direction to all programs to be undertaken like smallpox, malaria, tuberculosis, HIV, leprosy and others. These programs are implemented all over the country uniformly, and it is responsibility of the state to provide funds to this. It is a responsibility of the central government to provide funds to the state government for implementation and execution of all the initiatives. Even the role and the responsibilities of public sector it could vary from the private sector. While the private sector institutions are more inclined towards curative aspects, public sector take a more holistic approach including research, disease prevention and control, sanitation and cleanliness mission. So, at the level of operation, the federal nature of constitution allows for two levels, union and state government as I mentioned earlier, and the 7th schedule of the constitution describes the three list union and state entailing the details of roles and responsibilities of at each level. If you look into the trajectory of the evolution of health policy in India, that how health became a major concern, and what were the plan of action, what plans, what policies were being crafted both in the pre-independence phase, during the independence, and subsequently the Bhore committee, which was of utmost importance, from then started the evolution of the health policies. But before that, I would like to talk about, give a review or a glimpse of health during the pre-independence phase. If you talk about the health factors in the pre-independence phase, the pre-colonial period, which coincides with the pre-capitalist period, structured healthcare delivery had clearly established three characteristics. Firstly, it was considered a social responsibility, and thus state and philanthropic interventions was highly significant. Secondly, the services that were provided by these facilities were provided free to all who availed them or had access to them. Caste, class and occupation did not however limit access. And thirdly, most of these facilities were located in towns, is projecting a clear urban bias. However, as the needs, it was generally believed that the Ayurvedic system of medicine, the dominant formal Indian system of medicine became stagnant after 10th century AD. And Unani Tibia, which was based on Greek medical theory, received greater state patronage until at least until the advent of Europeans on the Indian soil. The first European to set up a medical establishment in India with the Portuguese. In 1510, the Royal Portuguese Hospital was established in Goa. This was transferred to the Jesuits in 1591, and it became one of the best run hospitals in the world. Of course, access was limited to European Christians only, though later Jesuits set up a separate unit to cater to Indian Christians. The English East India Company, they had set up the first hospital in 1664 at Fort St. George in Madras, because they could not see the Englishmen drop away like dogs, especially the soldiers, because of these diseases. This was followed by hospitals in Bombay and Calcutta for the same reasons. On 1st January in 1764, the Indian Medical Services was founded, initially as the Bengal Medical Service. As the needs of the British population, especially the armed forces, increased due to larger territories coming under their administration, and there was an increased number of English troops, a more organized medical establishment was necessitated. The IMS catered mostly to the needs of the armed forces. However, by the early 19th century, hospitals for the general population were established in chief Mufassal towns beside the presidency headquarters. So, the expansion of medical facilities followed by the devolution of the imperial government, especially after 1880 with the setup of municipalities and district boards. However, these medical facilities had a distinct racial and urban bias. Separate provisions were made on employment and racial grounds, though in some places non-official Europeans were allowed access to hospitals designed for civil servants. In general, wards for Europeans and Eurasians were separated from those for the rest of the population. So, these facilities till the Montague-Chelmsford reform of 1990 were located in the urban areas, in the military and civilian enclaves of the English. Another aspect which received early attention, at least in the cantonments, were public health measures. The continued high mortality of the British soldiers, despite good access to medical services, led to the appointment of a royal commission to inquire into the sanitary conditions of the army in 1859. Fevers, intermittent, remittent and typhoid, cholera, dysentery, smallpox, spleen disease, diarrhea, rheumatism, such kind of disease which were being found station after station. So, epidemics had happened. The result of imperfect civilization removal causes prevailed in India at the present day, as epidemics used to prevail in the Europe in the Middle Ages. The work of civilization and sanitary improvement has yet to be initiated in our country. However, the prevailing causes were everywhere the same due to certain hygienic issues like stagnant water, filth, damp, drainage system, want of drainage system, bad drinking water and all that. Preventive health measures, however, with this, after the recommendations, preventive health care consequently began to get some important, at least in the cantonment areas, and within within 30 years of creation of such commissions, the death rise in the army decline, within 20 years of creation of such commissioners, death rate in the army declined from 69 per thousand in 1857 to about 16. But in the general population, mortality due to diseases emanating from insanitary conditions continued to be extremely high. For instance, just 4 diseases, cholera, smallpox, fever and bowel complaints in 1886 claimed over 3,68,000 lives in Madras Presidency alone, in contrast to 3,68,000 deaths in 50 years ending 1886 from 4 countries, namely England, France, Germany and Australia on the Austria on the battlefields. The rural areas had to wait till the Government of India Act of 1990, whereby health was transferred to the provincial governments, and the latter began to take some interest in rural health care. In fact, rural health care expansion in a limited way began in India first from 1920 onwards, when the Rockefeller Foundation entered India and started preventive health programs in Madras Presidency in collaboration with the government, and gradually extended support for such activities in Mysore, Travancore, United Provinces and Delhi. The focus of their activities was on developing health unit organizations in rural and semi-rural areas, in addition to support for malaria research and medical education. So, this intervention of Rockefeller Foundation historically was very important for the development of healthcare services and health policy in India, especially for the rural areas. It may be considered a watershed that paved the path for the ideology that rural areas need only preventive health care and not hospitals and Medicare clinics, that is, they needed public health and not medical care. The result of this was that medical care activities of the state were developed mainly in the urban areas, and rural areas were still deprived the devolution of medical care within their reach. However, this important historical fact to note, because of these same differential treatments for urban and rural areas have continued even after independence for many years. However, with regard to public health, the same biases had been seen earlier. And at that time of period, only Europeans enjoyed the benefits of civic concern. This racial distinction and much more pronounced role taken by the state in Indian towns provide the main points of difference between the Indian and the British experience. Despite having a more centralized, active and interventionist government than in Britain, and one that attempted to draw on British experience, India gained only few benefits. During the colonial period, hospitals and dispensaries were mostly state owned or state financed. The private sector played a minor role as far as this aspect of healthcare delivery was concerned. However, the private health sector existed in a large measure as individual practitioner. The earliest data available on medical practitioners is from 1881 census, which records 108,751 male medical practitioners. Female occupation data was not recorded. However, of these 12,620 were classified as physicians and surgeons, qualified doctors of modern medicine, and 60,678 as unqualified practitioners, which included Indian system practitioners. And in addition, there were around 582 qualified medical practitioners, serving in army hospitals. However, the census does not reveal the proportion of private practitioners. The earliest data available for private practitioners is for the year 1938, when an estimated 40,000 doctors were reported to be active. Of these, only 9,225 or 23% were in public services, and the rest in the private practice or private institutions. So, the above historical overview was necessary to understand the development of healthcare services in the post-independence period, and one can see a remarkable continuity in the pattern of development of healthcare service from colonial into free India. The Bohr Committee, reported report corroborates this when in 1914-42 it reports that 47,524 registered medical practitioners in India, 17,654 graduates and 29,870 licentiates. Of these, only 13,000 or 27% worked in government and other agencies, including private institutions, and remaining were in private professional practice. Besides, they were practitioners of non-allopathic system, both of formally trained variety and informal inheritors of medical practice. One estimate reveals that there was one Vaid Hakim per 4,285 population in 1868, that is about 47,000 known indigenous practitioners. However, but in the independent India, the scenario changed, and a brief review of the Bohr Committee report is presented to demonstrate that the opportunity for the radical transformation of the healthcare system in India was available on the eve of independence. 18 October 1943 marks a watershed in health policy making and health planning in India. It was a great historical moment in the midst of the World War II, and in succession to the Quit India movement, the Government of India, Central Government of British Indian provinces announced the appointment of Health Survey and Development Committee under the chairmanship of Sir Joseph Bohre. Its secretary was Dr. K.C.K.E. Raja, and one of the joint secretaries, Dr. K.T. Jungalwala. Some of the well-known members included Dr. J.B. Grant, Dr. B.C. Roy, Pandit P.N. Sapru, and Dr. A.L. Mudaliar. The terms of reference to this committee, popularly referred to as the Bohr Committee, were simple. They focused on two important parts. First of all, broad survey of the present position in regard to health conditions and health organizations in British India, and secondly was a recommendation for future development. Prior to this, in 1938, the Indian National Congress established a National Planning Committee, NPC, under Jawaharlal Nehru. One of its subcommittees was a national health under the chairmanship of Colonel S.S. Sokhe, and on the basis of an interim report of National Health Subcommittee presented to the NPC in August 1940, the NPC resolved that India should adopt a form of health organization in which both curative as well as preventive functions were suitably integrated and administered through one agency. Such an integrated system of health organizations can be worked only under the state control. It is therefore recommended that the preservation and maintenance of the health of the people should be the responsibility of the state. There should be ultimately one qualified medical man or woman for every 1,000 population and one hospital bed for every 600 of population. Within the next 10 years, the objective aim at should be one medical man or woman for every 3,000 population and a bed for every 1,500 of population. This should include adequate provisions for maternity cases. The medical and health organization should be so devised and worked as to emphasize the social implications of this service. With this object in the view, the organization should be made a free public service manned by whole-time workers trained in the scientific method, and then adequate steps should be taken to make India self-sufficient as regards the production and supply of drugs, biological products, scientific and surgical apparatus, instruments and equipments and other supplies. So, no individual or firm, Indian or foreign, should be allowed to hold patent rights for the preparation of any substances useful in human or veterinary medicine. The Bohr committee endorsed this resolve of the NPC through its recommendations. In formulating its plan for a national health service, the Bohr committee set itself the following objectives. The Bohr committee had also recognized the vast rural urban divide or the disparities in the existing health services, and hence based its plan with specifically the rural population in mind. It had planned for, it plan was for the district as a unit, as a unit. Two requirements of the district health schemes, which are the peripheral units of the health organization, should be brought as close to the people as possible, and that the service rendered should be sufficiently comprehensive to satisfy modern standards of health administration. If you look into the certain objectives of the Bohr committee, the first, that the services should be make adequate provision for the medical care of the individuals in the curative as well as preventive fields, and for the active promotion of positive health. Secondly, these services should be placed as close to the people as possible in order to ensure their maximum use by the community which they are meant to serve. Thirdly, the health organization should provide for the widest possible basis of cooperation between the health personnel and the people. Fourthly, in order to promote the development of the health program, on sound lines, the support of the medical and auxiliary professions such as those of dentists, pharmacists and nurses is essential. Provision should therefore be made for enabling the representatives of these professions to influence the health policy for the country. Then fifth, in view of the complexity of modern medical practice from the standpoint of diagnosis and treatment, consultant laboratory and institutional facilities of a varied character which together constitute group practice should be made available. Thirdly, special provisions will be required for certain sections of the population, example mother, children, the mentally deficient, etc. No individual should fail to secure adequate medical care, curative and preventive, because of inability to pay for, and the creation and maintenance of as a healthy an environment as possible in the homes of the people, as well as in all places where they congregate for work, amusement, recreation are essential. So, these were the certain important objectives of the Bohr committee. Now, if you look into the inception of health plans and policies, so with the end of the colonial rule in the Indian population of the country expected a more radical transformation of the exploitative and social structure that the British rule had nurtured and consolidated. So, structured health policy making and health planning in India is not a post-independence phenomena. In fact, the most comprehensive health policy and plan document ever prepared in India was one on the eve of independence in 1946, and this was the Health Servant Development Committee report, which I have just mentioned, popularly referred to as the Bohr committee. And this committee prepared a plan of action or a plan of a national health service for the country, which provided a universal coverage to the entire population free of charges through a comprehensive state-run salaried health services. And the groundwork for the healthcare framework was indeed laid down by the Bohr committee's well thought out report in 1946, which I have just mentioned the objectives of that committee. The country's attention was focused on controlling and eradicating several communicable diseases in the first 3 decades post independence. Thus, it was only in 1983 with these recommendations and with the objectives of the Bohr committee, it paved the way, and it was only in 1983 that the country formed the first national health policy with the goal of improving healthcare services. The national health policy then again in 83 was replaced by the National Health Policy of 2002, which in turn was replaced by National Health Policy of 2017. So, several other policy initiatives were taken up and which are still functioning, like Pradhan Mantri Swasthya Suraksha Yojana or National Rural Health Mission, or which has now subsumed under National Health Mission, and then Rashtriya Swasthya Bima Yojana, Pradhan Mantri Jan Arogya Yojana, Pradhan Mantri Ayushman Bharat, all these infrastructure, health infrastructure mission, Prime Minister they have taken a lot of initiatives in the health sector, and the key themes which had been prevalent on most of these policies and specific initiatives included increasing public health spending and reducing out of pocket or catastrophic health spending, addressing rural urban inequalities in healthcare sector, developing primary health care, and achieving universal health coverage. That is all about today's lecture. I will stop here. In my next lecture, I will continue about the health policies and the first 5-year plans draft. Thank you.